All right. Next up, Cassandra Vale. Cassie is one of the team leader pharmacists at the intensive care unit at the Prince Charles Hospital for the last 5 years. Prior to that, spent the previous 5 years in the heart transplant unit, and that's roughly the time I've been a consultant there. And Cassie is interested in antimicrobials, I should know. Not uncommonly after an ICU round, she asks incisive questions that makes me reconsider my decision. So welcome, Cassie.
All right. Good morning, everyone. Thanks for your attendance today. I'd like to thank the organisers for the opportunity to speak, and I'd also like to thank the sponsors for the opportunity to have this event. Now, I have one disclaimer. This is pretty dry. Antifungals and monitoring is not everyone's cup of tea, and it's not going to light a fire for everyone, but it's pretty hard to spice up otherwise, so bear with me. So the first question is, why do we need azoles? And the reason that we use azoles is that there's a cumulative rate of invasive fungal infections of roughly 1 to 12% in the first 12 months following a solid organ transplant. And this is where we correlate with the highest degree of immunosuppression across the board, regardless of the organ, and also the cessation of post-transplant prophylaxis, which, as we've discussed extensively today, varies from centre to centre, patient to patient, and sometimes consultant to consultant. But what we find is that post-transplant prophylaxis will vary anywhere from none up to 12 months post-transplant. Invasive aspergillosis occurs in roughly 15% of all solid organ transplants and holds a significant mortality of about 25% overall, with our lung transplant cohort being disproportionately represented with up to a 70% mortality rate. And this is confounded by the fact that there are variable presentations that lead to delays in diagnosis and treatment. There's quite often an insidious onset, and patients may not present in the way that we expect them to. In terms of azoles and immunosuppression, there's a number of mechanisms by which they can be interactions that we need to be mindful of. And there's a couple here that I've just listed, but basically we're looking primarily at P-glycoprotein, which is located in the kidney, liver, small and large bowel. And this raises the question of the interaction if we're changing from oral to IV therapy or vice versa. We also know that azole antifungals are both inhibitors and substrates of CYP450. So while they go about doing their job of inhibiting enzymes, they're also increasing their own levels, and we have this kind of self-fulfilling prophecy of increasing inhibition and levels, etc. P450 enzyme inhibitors can exert effects after a single dose, but can take up to a week to resolve. So that has implications if we're stopping or starting therapy on other medications such as immunosuppression. And we also know that there is a significant genetic polymorphism in a lot of our CYP enzymes, particularly 2C19 and 3A4, 3A5. So inter-patient variability can have up to 4 times variation in clearance, and the rate of clearance can actually vary over a patient's treatment period. So does TDM really matter? And I thought this was a really good example. So this is a single German transplant facility that looked at 173 lung transplant patients over 2012 to 2015 who were receiving azole prophylaxis or treatment. And they were all lumped in together because it was the same dosing strategy, regardless of prophylaxis or treatment. And what we find here is such a discrepancy in the levels that were achieved in these patients, despite using manufactured recommended dosing, anywhere from almost undetectable levels of voriconazole to 7, which is quite high, posaconazole liquid, which is the bane of our existence if we're ever using it, routinely barely therapeutic, and posaconazole tablets exhibiting a fairly similar discrepancy across patients. So why and when do we need TDM? Why? We know that azoles and immunosuppressants have narrow therapeutic indexes. We know that there's significant impact of drug interaction, patient factors, and pharmacogenomics on levels. There's significant adverse effects associated with supratherapeutic levels of both azoles and immunosuppressants. And there's also significant risks associated with treatment failure of subtherapeutic levels with both. And so we would probably consider doing TDM azole specifically after initiating an azole. After initiating or ceasing an enzyme inducer or inhibitor that will impact azole levels. After initiating or ceasing medications that affect gastric transit or pH. Now, this is not essential for all azoles, which we'll talk about, but is something that's quite often overlooked. We could consider it if there was suspected changes in GI motility or absorption. So if someone had a gastrointestinal procedure, if they had an ileus, if they had changed their diet, looking at things like NG feeds versus normal intermittent feeding, and also if we suspected non-adherence. And despite individualized treatment by optimizing TDMs, azoles are often still poorly tolerated. And these are just a couple of the side effects. There's a whole host of them, but agent-specific, fluconazole can cause GI disturbance, dizziness, headache, hepatotoxicity. Itraconazole, GI disturbance, sleep disturbance, fluid retention, edema, adrenal insufficiency. Voriconazole, hepatotoxicity, visual disturbances, peripheral edema, photosensitivity, paresthesias, and posaconazole can cause peripheral neuropathy, neutropenia, peripheral edema, and adrenal insufficiency. So they're certainly not without risk. So on to our agents. First off, we have fluconazole, which is an azole that's active only against Candida species. Therapeutic drug monitoring is not routinely required given the high correlation between exposure, or the AUC, and dose, although recent studies have demonstrated much greater interpatient variability in exposure between critical patients and healthy volunteers, which we would probably expect knowing the changes that occur in critically unwell patients regardless. It's generally accepted that an area under the curve over MIC or a dose over MIC of 50 to 100 is in the target range, and that correlates to a trough level of about 10 to 15 milligrams per litre. Fluconazole is a CYP enzyme inhibitor, 2C19 much more than 3A4, and most importantly, it is over 90% renally cleared, because we have a tendency to look at fluconazole and say it causes hepatotoxicity, it inhibits enzymes, it has all of this liver stuff, and we often forget that it needs to be adjusted in renal clearance, and actually quite significantly. Itraconazole is a broad-spectrum antifungal which has terrible bioavailability, so anywhere from 40 to 60%. The liquid absorbs better than the capsules, which I know is very counterintuitive. And there is in Europe super bioavailability, or SUBA, itraconazole tablets, so something just to keep in mind, because when that eventually filters through to us in 25 years, that will be useful. Absorption of itraconazole is enhanced by lower pH, so a fasting or acidic intake, and slower gastric transit. And so with that, we need to consider things like ileus, which is going to slow or actually prevent gastric transit, NG feeds and the impact of pausing feeds so that we have an acidic environment, nausea, vomiting, and other medications, so things like PPIs and prokinetics that are going to affect both pH and gastric transit. Itraconazole is extensively hepatically metabolized by CYP3A4. It has an active metabolite with clinical activity, which we'll talk about later. It significantly inhibits 3A4 and P-glycoprotein, and is also extensively protein-bound and highly lipophilic. And the reason that I've included that, not so much the protein-bound, but the unbound fraction that's highly lipophilic, will have two main clinical applications when we're talking about dosing and monitoring. So first of all, people with a large lipophilic volume of distribution, and also if they're requiring extracorporeal support, so ECMO patients are another classification. Voriconazole is another familiar face, so it's a broad-spectrum antifungal that conversely has excellent oral bioavailability of almost 100%. Voriconazole demonstrates extensive nonlinear and saturable hepatic metabolism via 2C19, which, as I mentioned earlier, is prone to significant genetic polymorphism and has certainly caused quite a few issues in some patients of late. Drug interactions, polymorphisms, altered gastrointestinal absorption, body weight, and inflammation have all been implicated in the hugely variable intra and inter-patient PK that's been reported. And what we're finding is in that discrepant numbers, that is not just patient to patient, that's level to level in the same patient as well. Voriconazole significantly inhibits a number of enzymes, 2C19, 3A4, 2C9, and 2B6. roughly 60% protein bound, so a much larger fraction that's unbound, and highly lipophilic. And voriconazole, for anyone who's used it, will know that there is very extensive documentation of exposure-related hepatotoxicity that affects up to 2/3 of patients, and neurotoxicity, primarily in the occurring as photophobia or visual disturbances in about 30% of patients. So again, not without risk. Posaconazole is our third broad spectrum antifungal, and is a useful one to mention because metabolism occurs primarily via glucuronidation, not CYP450. So in patients where you're having difficulties achieving therapeutic levels because they most likely have a CYP polymorphism or suspected because a test takes about 2 weeks to come back, this is a useful option to try because it doesn't rely on the hepatic enzymes for metabolism. It does, however, still strongly inhibit 3A4 and P-glycoprotein, highly protein bound and highly lipophilic, but somewhat counterintuitively is not recommended for cerebral infections because there's a huge variability in the CSF to serum levels that have been reported in the literature, anywhere from 0.5 to 200%, which makes it unreliable when we're treating CNS infections. Posaconazole also has 2 different oral formulations with significantly different PK and dosing regimes. Absorption in this case is actually enhanced by food, particularly higher fat meals, which give a higher pH, and slower gastric transit will also help with absorption. So the 2 different formulations are the suspension, which is dosed at 200 milligrams QID, versus the XR tablets, which is 300 milligrams daily. So already insinuating that the tablets are much more reliably absorbed. The absorption of the suspension is pretty dreadful. Anywhere from 8 to 50%, depending on intake with food, and there is significant effects of pH and gastric transit time. So you can imagine someone that is critically unwell, needing an azole that you don't necessarily want to use IV, and the suspension's the only option down the NG, you're almost better off not using an azole or posaconazole in this situation. The XR tablets have a much more reliable absorption, greater than 50%, and the effective pH and gastric transit time is mostly not clinically relevant, which makes it a much better alternative if your patient can swallow. And I thought I'd chuck in a slide about savuconazole. I don't know if anyone's had much experience with this particular agent. It's the newest azole antifungal active against Aspergillus and Mucormycetes species. It is, again, on the horizon in Europe and is slowly making its way to Australia, so fingers crossed. Excellent oral absorption with negligible impact by food or pH, which is fantastic. It's demonstrated linear dose proportional PK up to 600 milligrams a day, which is actually the loading dose. So anything less than that, which is our normal daily dosing, is pretty much linear and dose proportional. Pharmacodynamic targets haven't been well defined, but because it's such a linear dose proportional PK, it's unlikely to be routinely required. Hepatically metabolized 3A4 greater than 3A5 and a moderate inhibitor of 3A4, so likely less drug interactions. Watch this space because it most likely has a better safety profile and less adverse reactions. So, the meat of the talk, azoles and immunosuppressants. Everyone gets a little bit nervous about the combination of these agents, and rightly so. For the most part, interactions between azoles and immunosuppressants, so either calcineurin inhibitors or mTORs, are mediated by CYP3A4 inhibition. And this is determined by 2 different factors. So the significance of the enzyme inhibition contributing to the reaction, and also the immunosuppressant that is impacted by the enzyme inhibition. So in terms of most to least, voriconazole and posaconazole are most likely to cause enzyme inhibition and contribute to reaction or interaction, followed by fluconazole, followed by itraconazole, followed by our yet to come friend isavuconazole. Conversely, in terms of immunosuppressants that are most impacted by this, we have sirolimus leading the charge, followed by everolimus, tacrolimus, and then cyclosporin. So when we're looking at these combinations, and this little table in the middle has some kind of widely accepted dose adjustments if we're looking at starting a combination. It is a bit hard to read and it's a little bit outdated. But what we find is obviously using two of the high-risk things together, so voriconazole and sirolimus, would be contraindicated versus something like isavuconazole and cyclosporin doesn't actually require any preemptive dose adjustment on either part. So it's important to take into consideration what agents we're using on both sides of the coin when making these decisions. Now, I thought I'd talk a little bit about the TDM, which again, this is the very dry end to the talk. Itraconazole exhibits nonlinear kinetics. A Cmin or trough level of 0.5 to 1 milligram per litre is widely accepted as being therapeutic, and that's with a HPLC. So when we're taking levels, we need to find out if it's HPLC because that measures only itraconazole, whereas there is also bioassays that measure itraconazole and its active metabolite hydroxyitraconazole, which were roughly 2 to 5 times the HPLC levels. And if we look at this little, diagram, as we would expect, people that have higher levels tend to be responsive to treatment, and that's with both the itraconazole and the hydroxyitraconazole groups. People that have lower levels are more likely to be in the non-effective groups. The threshold for toxicity is not well defined, but is roughly kind of accepted to be greater than 4 milligrams per litre. And given the long half-life of these agents, we would usually recommend taking a level at 5 days post-load or 10 days in steady-state therapy. Voriconazole similarly exhibits nonlinear kinetics. Again, not a great evidence base for what we should be targeting with our treatment, but it is widely accepted that a Cmin or trough level of greater than 1 to 2 milligrams per litre is required for treatment. And again, on this table, surprisingly enough, people that have higher levels tend to do better in terms of treatment success. Having said that, when we're treating to higher levels, we do need to be very cautious of all of the dose-related adverse effects that include hepatotoxicity and sometimes patient intolerable photosensitivity and neuropathies. And to that point, we would generally say anything less than 5 would be within the acceptable range for treatment, and anything above 5 would probably constitute a toxic level. The maximum clinical response has been correlated with a trough level of roughly 3 to 4 milligrams per litre, and that achieves success in about 63% of patients with aspergillosis. So probably a little bit higher than a lot of centres are targeting, and almost bordering on what we would consider a toxic level. Prophylactic targets, again, less well-defined and often site-specific, roughly 0.5 to 1 milligram per litre. And we would recommend taking levels 2 to 3 days post-load or at 5 days post-steady state. Now, posaconazole, unsurprisingly, also exhibits nonlinear kinetics. Target levels, unsurprisingly, are still not particularly well defined. Widely accepted that a trough level of 0.5 to 0.7 for prophylaxis and 1 to 1.5 for treatment, with a toxicity threshold of about 3.5 milligrams per litre. And it's really important to consider the formulation that the patient's on, which we have discussed earlier. If we look at the table on the side, these are all patients that have transitioned from the suspension to the tablets, and almost consistently the levels have increased once changing over to the extended release tablet formulation, which we know has much more reliable absorption. We would also take levels roughly 5 days post-load or 7 to 10 days at steady state. So where to with azoles? Integration of routine interval monitoring into clinical practice, better stratification of trough targets for prophylactic and treatment doses and correlations to outcomes, consideration of pharmacogenomics to direct azole selection and dosing, and patient-focused care for optimum patient outcomes. Thank you. Thanks.
I believe I might have been neglecting some online questions. If you can just bear with me. No, none on there. Any questions for Cassie? I didn't realize how highly potent bound itraconazole and posaconazole are, and some implications for some of our ICU patients.
Nightmare.
Thanks, Cassandra. That was a brilliant talk. You mentioned in one of your slides that from a pharmacogenomics point of view, there could be up to 4 times the variability, which is quite astounding. And then on your last slide, mentioning a sort of pharmacogenomic approach to more sort of personalized dosing. Do you think that that is a way forward? And can you comment in terms of sort of the turnaround time and sort of real-time azole drug levels and how that's likely to benefit patients?
That's an excellent question. And I've always been quite passionate about pharmacogenomics because we get so hung up on saying, well, they're on this and that interacts with that, so let's reduce this by 50%. But to be honest, 90% of it is really dictated by what your liver enzymes are doing, and what my liver enzymes are doing is not the same as what yours are doing and probably will be different tomorrow. We have had a couple of patients, which I mentioned, that have had issues achieving therapeutic levels with azoles. And so one example was a 40-kilo lady with aspergillosis who was barely therapeutic on voriconazole despite being on 400 milligrams TDS, which is an extraordinary dose. So we actually sent her off for 2C19 testing through Sully and Nix, and that takes about 2.5 to 3 weeks to come back. So in the interim, we changed her over to posaconazole and obtained therapeutic drug levels. But I personally think that it's, while it's not useful for everyone, it's definitely a good backup option if you only have limited therapeutic options, particularly in the context of immunosuppressants or azoles with really narrow therapeutic index. It will just help to guide rather than chasing your tail and saying, why is this patient super therapeutic when we started them on 1 milligram BD of tacro, and why are they subtherapeutic when we've got them on 12 milligrams BD? If that answers the question.
Sometimes hepatic fortitude works against you, it seems.
Oh, absolutely.
In anonymous attendee, in what clinical situation would you use the posaconazole suspension? Have yet to come across it.
Personally, I would never use it. But there are concerns. The IV solution does contain SPECT, which people do get quite concerned about because there is some articles or some literature supporting the fact that SPECT accumulation and renal impairment may worsen renal outcomes. That's I feel largely been debunked, but it is still a concern. So if we were trying to avoid the IV and we couldn't give tablets, then there's a very niche option for using the liquid. But to be honest, we've never had someone therapeutic on the liquid when we've been in that really tight space where we don't have any other options. So I would just use another option until they have the availability of oral access.
I think Dr. Gardner has another answer.
No. Another question. I'm just inspired by that, right? Because in the ICU, it's a bit of a problem, right? So what are your thoughts on crushing it and putting down an NG tube? There was a presentation at Ishult last year where they've done that. And so we tried it a couple of times in the ICU and it seemed to work okay, but have you guys done it or yeah?
Is that
got levels, therapeutic levels?
Yeah.
And does that change like the duration? Did you have to split it if we're crushing it?
No, we just did like 300 daily. And then, I mean, I don't know how long it took the nurses to squirt it down or whatever, but maybe a little while, but it seemed to get therapeutic levels just like,
I'm locking that away.
Thanks very much. That's helpful.
Awesome.